For atrial fibrillation, we were using it more for atrial flutter. There's another type of...
The difference, excuse me, between
these
two things.
Atrial flutter is a heart rhythm that generally comes from the right side of the heart, from the right atrium, as opposed to the atrial fibrillation, which comes from the left atrium. This patient actually had both atrial fibrillation and atrial flutter. And following the atrial fibrillation ablation, I then moved my catheters to the right side of the heart and did an atrial flutter ablation. So he got both types.
And you're looking here again at the rhythm of the heart?
Yeah.
Right.
And actually at this point in the procedure, where...
what is that, Doctor?
That's the heart rate. So the patient's heart was going 120 beats a minute. And it's doing that because we have him on an adrenaline-like drug.
Yes.
And so for this patient, actually this patient in particular, when he did activity, he would have atrial fibrillation. So we really want to test that hypothesis. And so obviously since we can't have the patient get up and exercise, we give them a stimulant to increase their heart rate to see if the ablation that we did just perform works.
Actually works.
Yeah.
Actually works.
Yeah.
This is a good question for this particular patient. Is this procedure more or less complicated if the patient has a pacemaker, which this one did have a pacemaker, right?
You know, it doesn't make a whole lot of difference, I wouldn't say, but there is a little more difficulty in getting transeptal access, so getting our catheters to cross over the septum because we have to stay out of the way of the previous pacemaking, of the pacemaking wires themselves. But as far, you know, it is kind of nice actually to have a pacemaker because they don't get a slow heart rate during the procedure, which can be a problem sometimes. But
So the pacemaker is still functioning,
potentially
functioning.
We do change some settings on the pacemaker during the procedure, and as Dr. Smith mentioned, when we're doing the transeptal portion of it, we have to take sort of great care not to dislodge that pacemaker that's in there. But it doesn't. I wouldn't say it's a contradiction at all in order to have this procedure. And following the procedure, since pacemakers actually monitor your heart rate, you're then able to look at the pacemaker, interrogate the pacemaker, and then determine whether or not the patient's having episodes of atrial fibrillation. They may not have felt their episodes, but we can then monitor.
You can tell.
Yeah,
Wow.
Exactly.
Doctor, I think you have some more slides that you might want to share with us as
Sure.
we continue our discussion and continue taking questions. One question, maybe Dr. Smith, you could address this, either one of you. Can AFib be controlled with proper diet and exercise? I think this is someone who really wants to not have any intervention other than lifestyle change.
Yeah.
And would proper cardiovascular training prevent the problem?
It can help it, but I don't know that it will completely eliminate it. But certainly, as we spoke about before, controlling your diet, watching your salt intake, caffeine intake, alcohol intake, all of those things go into helping control atrial fibrillation. But would changing your diet and exercise, all of those things, completely eliminate it? Probably not.
Probably not. Okay. All right, let's take a look at the slides.
So what we're looking at, the viewer earlier had a question about the esophagus. And what we're looking at here on the left is a CT scan of the heart. And if we can just pan out for a second so I can show the viewers. This is the left atrium we're looking at here. And this area here is the esophagus. It also runs all the way down here. And so you can see the esophagus is in very close proximity to the left atrium.
Yes.
We're aware of that, and we do everything we can to protect that from injury.
Wow.
And here is actually, this is actually an EGD or upper endoscopy that was performed while someone was ablating. So on the left, you can see that this is what the esophagus normally looks like. And on the right, you can see the external pressure from the radiofrequency ablation catheter is actually compressing the esophagus. So again, it's important that you know this, that complication that we have seen, specifically it's called an atrial esophageal fistula, can happen, but the incidence is very, very low, very, very low.
And just for my own edification, this patient is breathing on his own during this procedure.
That is correct.
No oxygen, no anything else?
Well, we usually do have some supplemental oxygen, but there is no breathing tube.
Right.
That is down. The patient is breathing on their own. We call it conscious sedation.
Okay. Another question for us, is there a significant risk to the patient due to radiation from the fluoroscopy? We talked about that a little bit when I mentioned that you were both wearing lead.
There have been people have had radiation injury, but I think those are things of the past. The equipment's better and the time of the procedure's better. So now at modern day electrophysiologic procedures, there's really not a risk of radiation injury.
Okay.
As I mentioned before, when these procedures were first started, they would sometimes go 12 hours. So not that the patient is experiencing 12 hours of x-rays, but there are a certain percentage of that time that x-ray is on.
Yes.
And now that we've been able to decrease the time to 4 hours, I would say that the average amount of x-ray time that a patient experiences is probably about 30 minutes. Sometimes can be less, sometimes can be more.
Much less than the original.
Right. And we rely a lot on the 3D mapping technology, the computer technology. Sometimes we don't even use fluoro. We can just use the 3D mapping technology. And that wasn't around 10 years ago. I mean, we didn't use it as much 10 years ago. So.
And how long have you been doing this procedure here in Baton Rouge at Our Lady of the Lake?
Since 07.
Yeah.
Couple years.
2 years. Yeah.
Coming on 2 years. Okay. This person writes, I have sustained AFib, persistent, I guess that would mean.
Yep.
Electrocardioversion did not work. My doctor has recommended a beta pace as the chemical conversion.
Yeah.
If this drug does not work, should another drug be tried before an ablation?
I think that's a similar question to the other patient who was on Sotalol, because beta pace and Sotalol are the same things.
Okay.
So I think that is a reasonable choice as a next drug for that patient, depending, as we talked about, other comorbidities, the patient's age. And whether or not you try another drug, again, depends on a lot of different factors, but it's certainly reasonable to try another different drug. Also reasonable, if they're a good candidate, to go and think about doing an atrial fibrillation ablation.
Okay. Let's talk a little bit about the post-op visits to the doctor. We talked about lifestyle changes, the importance of that. How often do you want to see a patient, and actually, when's the first post-op visit?
Sure. For me personally, we see the patients the next day. We do keep our patients overnight, and we observe them for any complications overnight. In the morning, they leave, and we ask that they no heavy lifting for a week. And then I have my patients come back at 4 weeks. At this point, we just sort of go over everything, make sure they're on the right medications, make sure that they understand what the next step is going to be. And for me personally, my next step is I stop their antiarrhythmic medication at 8 weeks. So we do continue them on their antiarrhythmic medications for 8 weeks, and then I'll see them back at 3 months. So usually for me, standard is 1 month and then 3 months.
Okay. All right. This person writes, if the heart rate is 147, is that a dangerous rate, or would I need to consider ablation? Do I need to wait? A lot of these are very personal and specific, and I know we're putting you on the spot.
We might change the answer. But, I mean, yeah, that is 147 dangerous? Not necessarily. It depends a lot on symptoms, the age, what other issues they may have. They really ought to just see how they're feeling. I mean, if they really feel poorly at 147, then they should go either to the emergency room or go see their physician. Most people at 147, though, can wait but call their doctor the next day.
Yeah. It's safe to say that that is an abnormal heart rhythm, and something should be done to lower that heart rate.
Okay. This person is addressing the whole issue of the sleep apnea. I have severe sleep apnea. If I sleep with my CPAP, the machine that helps control that, will it correct the atrial fibrillation?
It's certainly been shown to lower the incidence. Whether or not it'll actually completely eliminate it, usually not.
Okay.
So you're going to usually depend on the same things we've been talking about with antiarrhythmic medication, or even possibly an ablation at some point.
I must tell you that we have hit on a very popular topic this evening, because I think I've gotten more questions handed to me than ever before on one of our webcasts.
Well,
so
it's a very common problem, and it's 2% of the population have it, 5% of the population over the age of 65, and 10% of the population over the age of 75. So this is something that's very common. And so, yeah, that does make sense.
When we were chatting before the webcast began, we were talking about the whole question of more men than women affected by this. And as you mentioned, women are living longer, and so women are going to start having this.
We do see more women as they age, but that's strictly a fact. If there's more women who are alive at that age than men.
So one day I may be calling on you. Here's another question for you. Do you use this procedure for SVT, supraventricular tachycardia, or what meds do you use?
SVT encompasses a lot of different arrhythmias, but certainly can be treated with an ablation. SVT is different than atrial fibrillation in the fact that usually it's one discrete area that we're able to ablate. So in general, it can be a shorter ablation, and it's much more a discrete area that we're going after. But similar technology, similar approach.
Okay. Now, forgive me if I mispronounce this medication.